here it goes. So a couple of things announcement-wise. One, so today, what I'm going to do is phrase it this way. It's got to be very difficult, I'm sure, to spend 2.5 hours trying to listen to me. I can't stand myself. So what I think I will do, since I do the same thing, is I'm going to try to get basically with the equivalent of the Monday, Wednesday lectures in, and effectively the same lecture I'm going to give Friday. And I know exactly what the topic is going to be because I get there with joints and arthritis at the very end. But what I'm going to be presenting to you now is basically what was the first 2 weeks of content. That's what I did last time. So that way we can get out of here around 5 as opposed to 5:30. Save yourself a half an hour, which is good. Because I mean, it's very difficult. We did this a lot. I did a lot of community college work, and I did a lot of. I had a nursing micro class that I did the same way. We actually had 3 hours with like a 15-minute break. It was a little bit different. It was a very intense program. That was a diploma program at a Shadeside School of Nursing. And I was working for Chatham University at the time, and it's tough to keep attention for those periods of time. So I can only imagine here it's fairly difficult. The only thing that made that a little different is sometimes it's a little easier with non-traditional students than with traditional students, just because there's so much stuff, so much things involved, and particularly this term because of the situation with the lab, which is concluding this week. And so that's why if you bomb the first test, you bomb the first test. We'll forget about it. If you did well, great, we'll hold on to it. The other thing is I sent you a link, and maybe Dr. Robbins had the same link. There's a link that I sent you about an assessment. Okay, you might remember seeing it. If I didn't, I'll resend it, doesn't matter to me. But if you complete that link here, it's a one-time offer. Just like I should have a home shopping network. That's right, one time, you have to just give me your credit card. You can pay $100 up front or $75 times 4. You just give us that credit card. So let's say the next test you end up with scale C+, and you complete that assessment, and I will know, because I get a list of who completes it. It's part of our certification process. So we are allowed, not often do I offer little extra credit things, but we are allowed to offer a quote incentive as per departmental policy. So that's why. So your incentive is if you would end up getting on that next exam C+, and you do the assessment. That's right, you will become a B-. So you get like a little mini grade boost, the next grade level. Whatever. If you happen to get an A, you're going to stitch it. Thanks for participating. You have lovely parting gifts. Sounds like it should be a wheel of fortune. I have an affection for the angels. If I said big bucks, no whammies, would that make sense? Yeah. It's called pressure luck, Mrs. Stern. So I always wanted to be a game show participant. So that's the incentive. So please take advantage of it. So it gives you an extra thing like that. That's a little boost. You can drop the first or the worst exam, even if it's not the first exam, it doesn't matter. Okay? So I think you need to be cognizant of all of that. So that's the first thing. Second, we'll try to get this done a little more. Maybe I'll just do the try to get it, maybe 50 minutes or 55 minutes, take a brief break so my voice can recover, and try to get us out here by 5 o'clock. And whatever I didn't cover from the previous week, I have recordings to send to you. You need to listen to. The exam will be the 29th. I'll do the same thing I did before. So everybody will be taking the exam, all of my sections, on the Wednesday. It's just convenient because I can get everything prepped for that. So that will be the exam. We'll do it here. And then unfortunately, we'll probably have to have a class afterwards. So be aware of that. I will hopefully, if I'm in a particularly good mood, which will be determined by Thursday night's outcome. It'll just take me longer to get over it if it's adverse. I will start to do those review recordings. Start getting them to you. I'll probably 2 or 3 like I did before as I'm trying to put the exam together. So that's all the announcements. So today I'm going to talk about osteoporosis. We're going to talk about basically go into joints and joint-related anatomy. That's what we're doing. The part that I sent you, now that we can get back to this, that I would urge you to look at was on that same PowerPoint where we're going to go down, is to do as I went over the fractures. It's important to understand how, to understand what the specifics about these fractures. Try to listen, if nothing else, to the section on the fractures, because I feel that's really good. To understand that, and also the healing of fractures, because I know there will be questions on that for the exam. And when the review recording, I will be as specific as possible, because I know there's a lot of material to assemble. But because you effectively have the better part of 2 weeks to study for it, Sans lab, so my colleague Dr. Robbins from here, will all be good, all be well. So that's the part I urge you to look at. I use the same thing. I say the same thing to every class. It's like a recording. I just embellish it differently, over time. So including the repair. And this is where I left it for everybody else. This is the idea. And this was effectively when we started Monday. We started with bone disorders. And bone disorders, it's really the significant portion of this nugget is osteoporosis. More than anything else, because all of us, most of the classes, if you're in nursing or health science, the vast majority of the students, the male to female, or the female to male ratio is about 80-20. The reality is osteoporosis follows a very similar ratio. It doesn't preclude men from having it, but typically, I would think realistically, the numbers are something to the order of 3 out of 4. And there are a lot of risk factors, and frankly, most of you have those risk factors just sitting here now, just by the very nature of gender more than anything else. So let's begin. First, there's a whole lot of different, what we call metabolic bone disorders. I'm only going to the ones that are the most common and basically pointed out here. There are problems associated with bone diseases that have other metabolic issues that can impact bone. There are hereditary conditions that affect the way bone is developed, or developed or not developed for that matter. I've had patients with this. So they're comparatively rare. Not so rare that you don't see them, but they're comparatively rare. Most of them are affecting genetic disorders of collagen and related connective tissues. I'm not including that. We talk about that, or depending on who works with you in AP2, in the immune system, that's kind of where you begin to look at it. We will look at it a little bit in things like rheumatoid arthritis, which is probably one of the things we are not going to get today when we look at things of arthritis. And they're not the only things. The effect that tumors have, tumors going into bone and weakening it, or creating irregularities in it, other diseases in the bone marrow. There's a lot of other stuff that can cause bones to deteriorate in odd ways. The misconception about osteoporosis I will get to. This is what a lot of people think, there's not enough calcium in the bone. That's not osteoporosis, it's these top two. Malacia is a suffix that means softening, so soft bones. And rickets, they're the same thing. The difference is it adult bone or growing bone, period. Nothing exciting about it. Both diseases, same cause, either absence of vitamin D or absence of dietary calcium. Where do we see these? Not here. Everybody in this room is going. You're all going to take different career paths and life paths. We all do, and you end up in different places. If you're in healthcare, a lot of times you'll end up in other countries. You'll go on medical missions. People with Doctors Without Borders and all the nursing and healthcare personnel that go along with it. If you go to war-torn areas, underserved areas, impoverished areas, areas after natural disasters, any of those areas, that's where you begin to see these problems. This is something that we used to see in our country but took steps to prevent. The way bone is made, it involves the relationship to absorb it, to the calcium, the way bone is made, and strengthened would be a better way to express it, from the calcium. And that calcium has to get into our diet, and we require vitamin D. So the two work in concert. Without vitamin D, you can't absorb calcium through the digestive tract. Without calcium, it doesn't matter how much vitamin D you have. So this was a problem years ago in this country, particularly during the Great Depression. That's nearly 100 years ago. It started, technically, the stock market's crash of 1929, just to give you a little history. And it's something I would expect. It's been my experience that you folks don't get quite the same history that we did. But even though history is history, it's just there's different emphasis points. I mean, we didn't have a 9/11 because it hadn't occurred. The seminal event that happened in my generation, which are baby boomers, children were born between 1945 and let's say 1960, post World War II, the people coming home from war, the men coming home from war, was the Kennedy assassination in 1963. That's sort of our common context. For you folks, it's different. But nevertheless, that was my dad's generation. And if you did not know it, people in this country were absolutely destitute. My dad was starving, meal to meal, money ran out, no place to live. Him, his dad, and he had a younger brother and sister who were twins. His mom had died of an infection back in 1927. How's that picture? So I got a whole lot of stories about him that I don't necessarily have to share with you, but you get the idea. I have an idea what that was like. So because of things like that, okay, the government, particularly its effect on children, because in growing bone it was worse, they did something that you just see every day. All you have to do is go into the dairy aisle and into those refrigerated areas and grab a milk. And what's it say on the milk? Vitamin D enriched milk. The milk, we know dairy is a great source of calcium. Basically, they created programs to create subsidies which are around today, like the WIC program, which is a wonderful program. If you know people who are involved, my daughter was involved with that. She was such she was a mom before she was 16, and it's also, when she was pregnant, to be able to make sure that you had that the mom, the baby, both pre, during, and post natally had sufficient amount of products that were going to keep everybody healthy. And so that's where it came in. So milk, vitamin D enrichment, the problem was solved to a certain extent. And even again, this is a lot of what things were done during the Depression to sort of, when they began to turn around and talk, the tide around, so to speak, during sort of the highlight of when FDR took office, Franklin Delano Roosevelt, in 1933. So on with it. So if it's adult bone, there's not a lot of mineralization. The osteoid, the matrix is produced. That the organic portion, but the salts are not there. Effectively, they're soft and weak, and it just hurts. In children, it's a little bit different because it affects the area of the growth plate particularly. And what happens, we typically, bow-leggedness is a big thing. Bow-leggedness is not that unusual for a lot of reasons, but if it persists into adulthood, other than being some irregularity in the foot, ankle, hip that you could identify, here you would see these bowed legs, elongated bones, okay? And what happened at the ends, like at the knee, it looked like this. So it kind of went up, and the upper growth plate almost widened. And what we used to see, even before that, the epiphysis portion of it would become the tibial portion of the knee joint. It almost looked like a little ball was forming. It really didn't have a lot of structure. It looked like the end of like a trumpet or a horn, a musical instrument. It's really the way we saw it. And I've never seen a patient, but historically we saw a lot of the X-rays when we were in school during our radiology and courses and studies of bone. But just to give you an idea what it was like, it was really an oddball. This is the point. It's stated well. It's a group of diseases. It's not one disease. The mistake that people make is they say, oh, I don't have enough calcium. It's not just the loss of calcium or calcium salts. It's the loss of bone substance. A lot of the bone is eaten away. And probably the culprit is overactivity of those cells called osteoclasts. But it's not clear what activates them all the time. There are different reasons. If you have hyperactive parathyroid, sure, we have a reason. And that's what we call an endocrine disorder. But we're not sure. There's a lot of factors that are risk factors. And the way for you to find out is look at your relatives. So assuming that you're able to, I have to express it the way my 3 children are adopted. They don't have the luxury of going to see dad or grandpa because they don't know anything about dad or mom or grandma. So when I say if you have your birth parents and you're able to, I'm not saying anything, trying not to say anything out of the ordinary, but that's just the way I'm used to expressing it. And what happens is you can look, if your mom, your grandma, okay, has it, there's a chance you have it. And then there's a variety of risk factors that are there. But there's certain things we know of. And of course, the areas of structural weakness, and we saw that. You see that if you go back and look at those x-rays. Because I have one here, and I didn't show it to you directly. I'll show it to you now. If you didn't get a chance to look at it, I guess most of you are pretty busy studying. Right here, this is a compression fracture. That's what we call it, a pathologic fracture. It means the bone's been damaged. I mean, it could have been a tumor, it could have been an infection. Most of the time, it's osteoporosis. Look at how the bone here, how washed out it is. Look how dense it is here. That's healthy bone, adult bone. This is washed out osteoporotic bone, most likely eligible, because that's who gets it. And it's there, and it's in the head, neck, femur area, particularly the neck, because that's where the weight is born. And so grandma didn't fall and break her hip. Grandma's hip broke. She fell. Depending on where the break is, it determines how we have to go approach it. I can't even begin to tell you in the 2 years I was an orthopedic resident how many hip fractures we had. It was amazing. I mean, all ages. I mean, it was not nothing unusual to have a 90-year-old with a hip fracture, once a week. That kind of thing. But we were an inner city population, a big population. So I'm trying to give you an idea, some context, but why all of this is relevant. Because it may not be relevant to you now. And the way I framed it with all the other students in the other 3 sections was the time to do it is not when you go and get an x-ray for something unrelated. And the doctor says, you had a chest x-ray because you needed one for your health insurance. You got osteoporosis. Oh, doc, what do I do to fix it? You can't. It's done. By the time it shows up radiographically, those bones are already 75% osteoporotic. All you can do is try to treat it. It's not going to go back. There's no magic pill. I'll take it back to normal. And the body does that a lot. I warn you. A lot of times when we find out there's something wrong, it's too late. So it's more the ounce of prevention versus a pound of cure is certainly accurate. So it's nothing else. I love those little cliches. Actually, they're useful. I say them all the time, but that's the way it works. So this is the area where you see it. That's moth-eaten bone. That's a micrograph, not an x-ray. So we're beginning to look very, very deeply in magnifying this many, many times in cancellous or spongy bone. And oh my goodness, that bone's, it's just an accident looking at it. And again, on a regular x-ray, you wouldn't notice that until it was already about 75%. And that's, again, it's true for a lot of things. Here's where the problem is. Most often aged and certainly postmenopausal. The biggest single risk factor that makes it more common in men and women than in men is estrogen. Women at menopause stop making estrogen, as you probably know. And at that point, what are you relying on? Men have testosterone. Men produce testosterone through their lifetime. It starts at puberty. It peaks shortly thereafter, and it stays relatively high to about 60 or 70, but it doesn't magically drop off a la menopause. It kind of just slowly slows down. It's a little, and it's different. So women who are reach menopause, women who are prematurely menopausal, or have some type of ovarian dysfunction, and that's a wide range. I told the whole class about my first wife. 5.5. I told you, maybe you remember, I told you, if I didn't, only 5.5 feet, 5 feet and a half inches tall. She's very short stature starter. She had all the risk factors that were there, except for the really bad habit part of the risk factors. But the nature of her coloring, the skin coloring to some extent plays a role. Her skin coloring is very Mediterranean. There are other members of her family who had suffered from it similarly. All of those things, and most importantly, one of the reasons we did not have kids biologically, she became effectively prematurely menopausal from ovarian dysfunction from Stein-Leventhal polycystic ovary disease around age 33. And because she was aware of all these risk factors, my first wife was hiring with a BSN. They put her on estrogen lozenges. At that point, the way they administered, the pharmacy made a lozenge that effectively you put sort of in your mouth and let it slowly absorb through into the bloodstream by all the blood vessels in your mouth, which a lot of medications are administered that way, but that was very unusual at that point. I think there are better ways to administer it now. And this was a fair amount of years ago. So that we're talking about her probably undergoing this in the mid-'80s. So as you can see, the numbers that are there, estrogen plays a big role. Men are less prone. Women, the only testosterone-like substances women produce, and they're very limited, come from a small portion of the adrenal gland that you look at an endocrine. It's really substantially less. It does have some significant features, but it's not substantially less. Look at the risk factors. And this is what she did, my ex did, to her credit, because she knew it was coming. Other than the estrogen supplements, she exercised a great deal. Okay, she had vitamin D in her diet, protein in her diet, calcium supplements in her diet. She had never smoked. The genetics were against her. She didn't have either of these conditions, and at best, we were an extraordinarily rare social drinker. Like you're going to the wedding or something like that and you're having a toast, that's about what you saw us drink. So it gives you kind of an idea of the severity of the condition. So these are the treatments that she did. The medications are less reliable. The real problem with a lot of these medications have been side effects. So they haven't come up with a magic pill, even though there would be a pretty substantial demand. Good news, if you're at risk and you speak with your family doc, your PCP, your internist, your OBGYN, whatever, and say, there are a variety of scans that are available now that can get an idea early on so you can start attacking. So this is more of a message to you. Get ahead of the darn thing. We don't tend to do it. We don't tend to be proactive, particularly young folks, because you're not in touch. I hate to say it. Most of you are not in touch with your own mortality. You don't think it's a little bit. It's not going to happen. I'm not going to get that kind of sick when I see because I'm healthy. I take care of myself. Blah blah blah. Some things are unavoidable. This is kind of in that category, depending on the fact. So I urge you from that aspect of things. And lastly, and you rarely see this. This is an oddball called Paget's disease. This is odd. It's almost irregular. We think maybe viral. There are some medications. Again, those are a lot. Those bottom two we use for osteoporosis. Bisphosphonates and the calcitonin. I mean, that's something that's at least being thought of to use for it. And what's interesting about that, okay, is it shows areas where there's very dense bone and areas where there's very, very almost osteoporotic bone. So it's this irregular pattern that we see. And really probably what you'll show here, the hip x-rays. So here you get these radiodense areas, a lot of calcium, and here you get these washed out areas. Where's the calcium? It's really odd. Don't see it a lot. I mean, but even though it may be denser here, it's still, this bone is inherently weak. There is a disease called Paget's disease because a lot of times it's either the same doctor or a doctor with the same name. It's actually a kind of breast cancer, interestingly. It's Paget's disease of the nipple that we see in women, and it's not as tragic as some of the others. I would never make an attempt to minimize it. But my mom happened to have that diagnosis. Fortunately, when they did the biopsy, she's probably in her 60s, mid-60s. The doctor who said to her, when they got the biopsy report back, said, "This is really good news. It's what's called in situ, which means nothing is spread." When they took it out, they got the whole thing out. And she didn't have to have radiation or chemo or any of that stuff afterwards, which is a blessing, no other way to say it. So, I mean, sometimes you see the name, make sure you read more or look at the chart more if you're looking at charts to get the appropriate context. That's sort of the bottom line of that. And I just sent you these. I sent you the joint ones. I sent you in this. So I uploaded, and now I'm calling this Unit 2 for whatever reason, even though there's going to be stuff previously on there. So remember I had the bone outline, and so I've added, this is the joint chapter from the Welsh Hole textbook that you have pretty much if you have the book bundle. And then I do not have an outline for this. I apologize. You won't probably see anything in the outline department for me because I didn't start making them again until endocrine. So I didn't have them for the muscular or the nervous system. I will look. I don't think I made one up because I made these up about 25 years ago, so it's a long time. But I'm happy to look. And so I did message you with these other PowerPoints. That's the joint stuff, and that's what we're going to go to next. As soon as I don't X myself out of it, put a dodo. There we go. Always have this little stuff. So you have that available to you. I did have a student who was having, the other class was having difficulty opening it. It maybe has to do with their system when I send those. What I had to do for her, and maybe you'll need to do that for you, is I converted these PowerPoints. You change it from a PowerPoint to a PDF. You just scroll through it. So if that's happening to you, holler at me. I mean, it's a click for me to do that. Send it. I can incorporate them, and if it becomes an issue, I'll just start doing it that way. Don't care. School pays for those programs. I don't have to. I'm not so technically advanced. We have to do that. So this is, and I understand, I know, but because of the overwhelming amount of stuff you had to do for the lab, that this is one of the things you didn't get. The joint thing, right? Hello, everybody out there? You didn't do the joint number. That's my understanding, right? We're doing it. So basically, welcome to anatomy lab. Nothing. Quiet. You guys have to speak up. And why, and frankly, is going to be on the exam, but not this stuff. There's very little, I'll be very specific of any of this stuff that's going to be on the exam. So I have to, basically, it's trying to give you the way I would do it in lab. But from a lecture perspective, parts that I'm going to test on are arthritis. I may ask a question or two about this and the 6 different categories of joints. That's the big stuff. Okay, this next exam will probably have between 55 and 60 questions. If there's probably 8 to 10 on joints. So if you're dedicating your studies, this would be the last chapter I would dedicate. Just saying. If you have to divide and conquer, you divide and conquer appropriately. They are called articulations, where bones come together. Number 1 in the hip break, the fact that it's a joint doesn't mean it moves. Major misconception. They are classified based on their structure and on their ability to move. We use the anatomical or structural classification because it's a little bit easier, I think, to understand because of the way it's identified. That's the one that you see on the bottom. So our articulation, those skeleton that they have hanging up there, that's called an articulated skeleton. You know, where this bone articulates with the other, where the bones come together. I'm not saying they move. It's still a joint. The bones come together. Movement is a luxury. So and obviously that's their function. There's nothing new under the sun about that. Structural tree, 3 types based on what material binds the joint and whether a cavity is present. The joint that we're going to spend time on when we start talking about the hip or the shoulder or the knee, any of those are synovial joints. Those are freely moving joints. Classification you will see there is called diarthroses. Arthro is the universal word for joint, like arthritis, inflammation of the joint. Arthrology, the study of joints. So arthro implies joint. So the term diarthrotic, to me, it seems like it should be two, because di is usually two, but we're not going to go there. That's the joint we're looking at. We're going to go up and show you the structure of the joint, draw it a little bit for you to give you an idea of what's involved with it and how intricate it is. I have a tremendous amount of familiarity. I spent 25 years operating on bones and joints, so I can give you chapter and verse on this stuff. Okay, so that is so most people think of it that way. The name for that is called a synovial joint because it specifically refers to the structure in the joint itself that produces the joint fluid, which is called synovial fluid. When we want to evaluate certain types of problems in a joint, particularly different kinds of arthritis or injuries, damage, whatever it is, we aspirate or suck out, that's really what aspiration means, a certain amount of that fluid and examine it microscopically, make sections out of it if we let it solidify. There's all sorts of things that we do. It's very important. So on with the structure. The first structure is called fibrous. What that means is a joint that is immovable. The joints that move the least are ones that are made out of fibers. The fibers are mostly collagen fibers. If they are longer fibers, okay, they move, they have actually a little motion. If they're very short fibers, they don't. Classic example, bones in your skull, sutures. Very, very short, taut fibers. And what happens as the bones enlarge, effectively those fibers shorten. When the baby is developing, there's a fair amount of movement as the brain forms and the structures form. There is still movement available. You might remember, you probably learned about it in lab. They're called fontanelles, little fountains, because they could distort to facilitate or enable the passage through the birth canal, which they do. And a lot of times, if you didn't know it when a baby's born, sometimes moms and dads kind of go, "Oh my God," because the baby's head is somewhat distorted. And it takes nurses and doctors to go, "Okay, you see this, don't worry, you're in an hour, you're not going to notice it. Things are going to straighten themselves out." It's not like all of a sudden you got something from a bad sci-fi movie. It's coming along. And really, that's kind of, and I understand there's a lot of that goes around. So you see a lot of times babies, there's bruising and black eyes, and all, oh my goodness. And people that's why information is important. That's there. Sin, think of in Spanish, sin means without. So sin is an immovable joint, synarthroses, and there's three types of these that you will see. I'll flip back. The ones that have a little motion have cartilage, particularly the ones with fibrocartilage, like the intervertebral discs that you learned about when you looked at vertebrae, and the symphysis pubis. Again, that relates to the birth process. So chemicals, hormones are related that are kinds of what we call relaxants. And what they do during as we approach the birth process for a vaginal delivery, they begin to cause that symphysis where the pubic bones come together to be just have a little more give to facilitate the birth process. So there's all sorts of neat little things that go on. The cartilaginous ones are called amphi. I don't know why. Amphi means slight or some mobility. And then let me go backwards once more, and then we'll get to the synovial joints. So that's the three categories. Now you're going to see the examples. It would be useful to remember maybe one example of each one. So what's paramount, what's extraordinarily important to understand, whether it's a fibrous joint or a cartilaginous joint, it does not have a joint space. Joints that move, there is a space between the two bones that's filled with a certain small amount of fluid that lubricates it. So we call it a discrete space. It's measurable. It's there. It can get bigger if it swells up. It can get smaller when it stops swelling up. But it's there. So the sutures, no space. Okay, there's no fluid in there. It's a sandwich when you think of the intervertebral disc. You got bone, you got the fibrocartilaginous pad, you got bone. Sandwich. Symphysis pubis, same deal. Pubic bone sandwich. They are, so there's no quote unquote space that's there or should be there. The space is there, it's unusual. So that's another thing to remember. It does not have that synovial apparatus. It doesn't require lubrication whatsoever. So the sutures are the first one, pardon me, of this. And they make these rigid. By the time the baby is about 2, the last of those fontanelles close. That's the one between frontal or coronal suture and the sagittal suture. That's the last one to close. That was a typical test question that you would get at A&P, at a lecture test for that, which is the last one to close. And it's got whatever name it has like that. And again, the connective tissue fibers allow for growth and expansion, but as we reach maturity, it firms up. So there's still going to be, even though it's not moving, when those fontanelles close, it doesn't mean that there can't be a certain degree of expansion. It has to do with the fibers permitting it. By the time you reach middle age, 40s, 50s, a lot of those, quote unquote, when we look at them after post-mortem, they're all bone. The conversion is gone, so now it's become all bone. Not that that's a big deal. And the fancy name they call is synostoses, and you don't have to. Sutures are all a little bit different depending on where they're located, just as a curiosity. Syndesmoses involve strong ligamentous structures, typically not permitting movement. There are 2 really good examples, and here they are: long versus short fibers. We're going to see shortly what's called the inferior tibiofibular joint. That is the joint at the bottom of your ankle where the tibia and fibula come together and effectively form that sort of cavity that the talus. So that's really where the true ankle joint is. The fibers, what's called the interosseous membrane between the tibia and fibula, does not move. They're short fibers, cross. It's not designed to move. Structures are there that take origin from it and attach there. There's openings in it that allow certain things, blood vessels and nerves, to go through without having to go crazy with the anatomy, which I know a lot about. Radius and ulna. When you pronate or supinate, effectively movement around those joints like that, the tibia and fibula don't move, but the radius and ulna do. They move over one another. They rotate around each other, that radial head and the radial notch. Okay. Because of that, there's a certain amount of built-in movement. The fibers are long. So they're not all created equal. This is that famous joint. So if you want to think ankle, okay? When you hear about ankle sprain, this is the ankle joint. A typical ankle sprain is down below it. It's called an inversion sprain. You're walking along, and all of a sudden you have a little chuckle, and you invert your foot. You'll see some lines. Subsequently, it's like the sole of your foot is pointing toward the midline. It's up, sort of rolled up on the outside. That's the classic ankle sprain. The ligaments that are involved, and we don't really study them in this course. They're called lateral ankle ligaments. So they start here. Well, the joint's up here. They start below here. They come from the tip of the fibula and go toward the talus and the calcaneus on the outer aspect of the foot. This extraordinarily strong ligament, along with the interosseous membrane above it, gets separated with certain kinds of severe ankle injuries. Really severe twists like that, sport injuries where the foot gets trapped and can't move or get off the ground. You see them a lot in a lot of different sports. Football always would be a very good example. That causes this to separate and rupture. That is what's called a high ankle sprain. The high ankle sprain is an ankle sprain that starts at the ankle joint and causes these bones to separate. In the old days, before we had MRI and CT, we would inject dye into the joint and watch it go up in between the bones. At that point, that would make the diagnosis up. High ankle sprain. And the difference is substantial. A grade 2 ankle sprain, typical ankle sprain that we call it inversion sprain, worst case scenario, a week or two. The trainers, when I started in college, have you running on a sprain in about 3 days. I mean, they were really good. And this was it's a long time ago. So, I mean, the state of the art of physical therapy and training and athletics has just evolved tremendously. It was amazing what they could do. Versus, okay, the high angle sprain, now you're looking at something 6 to 8 weeks, might require surgery. So in the old days, we had to put a screw across this area. Nowadays, they have like it's like a band, almost like a cinch that you drill holes in the bone and cinch it to hold it together. It's more dynamic. In a sense, it has a little inherent give to it, which may very well be useful, yet still ensure a sufficient amount of stability. So, I mean, if that's the kind of stuff that you're interested in, and it really is, you can Google that stuff, and you'll get all sorts of links that'll tell you, how are they taking, what's the surgical approach and the non-surgical approach to high ankle sprains or to other types of things. They have all sorts of interesting stuff if you like to read about that. It's fun to read about that stuff. So as an aside, if you're going into a healthcare field, it wouldn't hurt you to every so often look, whatever news sites you look at, when you see something that's health related, we're doing a new treatment for this, a new operation for this, new medicine for this. Take a look at it. I did that this morning. I mean, it was an article of something I already knew about. I just wanted to see where they were going with it. And now we're starting to see in mainstream media outlets talking a lot about a really significant problem that we talk about in micro, which is we're getting to the point where we're really running out of effective antibiotics. It's a big problem. That's one of the highlight things I do with my micro classes. Moving on. The last one of these is called the gomphosis, peg and hole, or peg and socket, whatever you want to call it. That's the periodontal ligament. That's the one when you're we're not talking about baby teeth and secondary teeth coming in. We're talking about when an adult has to get a tooth extracted. That's the part that's really hard. They have to get down here into that base and basically pop that out at the root level. Sometimes, like in a molar, there's more than one. And that's really what makes the difficulty in extracting. So if somebody has their wisdom teeth out, sometimes it's quite a bit of a struggle. Not everybody's awake to have those done, or sufficiently sedated, but some of them are not an easy removal. And so again, cartilage pad in between, that's the cartilaginous joint, no joint cavity, a little bit of motion. The symphysis is the one you should know about, not the synchondrosis. The synchondrosis is basically effectively, it's not a term we use a lot clinically. This is basically what an epiphyseal plate is, and it changes and becomes bone. Okay, they talk about the one at the first rib where it joins the sternum. Okay, I'll buy it. Again, it's not a term that I utilize, nor in my years of working in hospitals and working in health, as a doctor. Nobody said. So these things. But symphysis is, those cartilaginous pads are big time players. They're really important. It still doesn't have a joint space. There's a slight amount of motion. And what we do with all of these joints between the pads and the small bones and the little bit of motion in each one of them, it allows us this tremendous range of motion. Let's say in our back, you'll be able to twist it or turn it if you're doing sport or you're doing an activity at home, or you're like me and all of a sudden you're trying to get down on your hands and knees and reach for something the dog knocked under something. It's a bad habit of crawling under the deck, which we are trying to break him and getting tangled. I'm on my hands and knees in the dirt with the dog. Not happy. So those are the ones to remember here. Classic examples. You probably did this in lab when you talked about bones. This is fibrocartilage. The inside it's called the nucleus pulposus. It's almost like a gel-like center. We use those, and that's when they rupture. Typically with those compression fractures that I was showing you before, this is what causes this area to create problems. Okay, that's those nerves coming out the intervertebral foramina get pinched. And here's the pubic symphysis. Synovium. As soon as I get through the basics of this, we'll take a break. The synovial joint is the true moving joints. They are pretty much universally like this. Doesn't matter which way you draw them. Look at them from the side. I'm just doing a generic joint, or look at them from the top down, or for that matter, the bottom up, whichever your point of view would be. And you have bone, and on the ends of the bone, what's left of the bone, because it's basically long bones, and they all effectively come from a cartilaginous shell, that endochondral ossification. You have cartilage, hyaline cartilage. Like so. And on top of that, or in addition would be a better word than on top, you have, remember, bone periosteum, the real important stuff for bone healing. It holds it in place. As it gets close to the joint, it changes. It's still thick and fibrous, but it lifts away from the joint here. It lifts away from the bone, rather, here and here, and away from the joint. Now it becomes something else. Now it becomes what's called the capsule. The capsule has very, very thick fibers on the outside, and on the interior, it's got a layer of squamous cells, simple squamous cells, that secrete joint fluid. They're called synovium. It's the name of that layer, that particular tissue. Fibers on the outside, so it's a thick outer layer that gives it strength. It's very, very elegantly designed. It's almost got a pattern, as though you would see it when you open one of these up. You can see almost as though they're sewn together accurately. So if you do any sewing, or you know somebody who does, my wife's fabulous seamstress. When you have a garment, how they'll make sure everything lines up, your body does that. We'll go in there and basically cut it to access it, to remodel the joint. And we will use those lines, because you can see them, and actually sew them together. Sort of like you buttoned your shirt and you went the wrong, you missed a button. You'll create an irregularity. The fancy name we give it in surgery called the dog ear. But really what it means is, that's something that will restrict motion if it's not done properly. So, the human body's great like that. Many of you, depending on where you're going, you'll probably observe a surgery. I know when my wife was in nursing school, she basically, they basically hand her a set of retractors and say, I need you. And she goes, I've never done this. She goes, don't worry, I'll tell you what to do. That's the doctor told her. And she did so well, he said, I don't need you to stay. I have 3 more cases. She goes, you're staying. And so you see a lot. You're opening it up, and if you got a strong stomach, and you have to, you got to put a look in there and go, wow. We're all like that the first time you see it on the inside. It's fascinating. It's a new world on the inside. So that just gives you an idea. And there's a lot of complexity. Along the sides, we have another famous structure called ligaments. They go from here to here. They hold things together. Or they from here to here, and they hold things together. And you're going to see different ones. And they're holding the joint, stabilizing it from side to side, or top to bottom, or in and out. And we'll cover all of those things, particularly when we get to the knee, which has the most complicated arrangement. I do not agree with whoever, I'm trying to phrase it the right way. It's not that I am disrespecting somebody who put time and effort, a professional, to try to make these PowerPoints, but sometimes they mess it up. And the point I've been making with all my classes today, we're in anatomy and physiology class. This is classroom anatomy and physiology. It's not clinical anatomy and physiology. It's different. When you hear terminology at the hospital, it's different. When you see surgical anatomy in surgery, it's different. So, this is done, anatomists use some terms in a collegiate or university or research setting. In a hospital setting, and if you're going in that direction, you will learn that. There's a whole, and you need to learn the language, so to speak, because that's how you're going to keep, you're going to be informed how you inform others. How you talk to patients, different ballgame entirely. You talk to them the way you would talk to anybody else. You just have to do it the right way. So these are fluid-filled cavity. They move pretty much all the limb joints. I don't know about 6. We're going to look at bursae and tendon sheaths. We're going to look at stability. This is where I disagree. Now, I'm going to stop there. We'll take a break. At the end of the bones, hyaline cartilage. It's what's left of the cartilage. It does not prevent crushing. It's about 1/8 of an inch thick. So if you jumped out of a window because the building was burning, that is not going to protect the end of your bones from crushing. It's 1/8 of an inch thick and it's relatively delicate. It's like having a little piece of plastic. Boom, and you're going to smush it. I don't know where they got this. So somebody, I must have read it someplace. Really? The synovial cavity, when they say fluid-filled potential space, if there's more fluid, it gets larger. If there's less fluid, it gets smaller. It's unique. The capsule has the outer fibrous layer, dense irregular, which is what capsules are made out of, what periosteum is made out of, what perichondrium, what the deep dermis is made out of, and the synovial membrane, which has those lining cells. And anywhere you have lining cells, you always have loose connective tissue because that's where it gets blood supply. Synovial fluid, we look at it. We sample it, as I said, but even in surgery, we cut in a joint, we look to see how sticky it is. It's viscous. It's not like water or a general solution. It's not like taking a drink of a clear, like a 7-Up or that kind of a beverage. It has a certain degree of viscosity. It's not like motor oil, but there's like an oily consistency, and then you can test it and look at it. And I would agree, lubricates and nourishes. There's white blood cells, a very tiny amount. And joints are free of infection. If a joint gets infected, very, very suspicious. And you'll learn if it's a case of trauma, if somebody fell and there was a puncture into the joint, you can understand that. Learn this. If an adult comes in with an infected joint, and that's the diagnosis, joint infection, most likely, and there's no history of trauma, most likely that is gonorrhea. Gonorrhea has an alarming tendency in adults, or anybody who has gonorrhea for that matter, to go to joints and cause an infected joint. Gonorrhea was rampant when I was a resident, rampant. Syphilis and gonorrhea were umpteen times a day. Because they were bacterial infections, people would come in and we had antibiotics, they'd come in for the cure. See you in 6 months, Charlie. All right. They didn't get. This is more of my repro lecture and my micro lecture on urinary tract diseases. People did not use barrier methods. They just didn't. Because they had that HIV thing nobody ever heard. That'll be part of mine. If you have me for micro, you'll hear about that. So it's part of that. Ligaments we're going to look at, but this is more in the context of the knee. They have a ligament. It's sometimes just a thickening of the capsule. Sometimes it's separate, close to the capsule, but you could put a probe in between it. And sometimes they're in the capsule. Guess what? The knee has all three. That's why it's so complex. One of the reasons why it's complex, along with those cartilages that are in there. And obviously nerves and blood supplies are there. It's and this gives you an idea. This is that fan folded. Anatomical position. Look at your elbow. Look at the arm and your forearm. Okay, they're relatively neutral. But if I do this side has to have accordion pleats. This side has to have pleats that will expand. These contract. And I straighten it out as it goes in the other direction. That's the beauty. That's what I was trying to, and my bad artwork doesn't do justice. But that's what I mean. That's a pleated system. And sometimes those pleats get trapped. Things get stuck into them. I mean, there's some things we see with sport injuries, some things we see with arthritis. My ex-wife was doing a lot of dance. When the kids were little, she was doing ballet and other types of dance. And she got one of these sort of, the pleats, the accordion pleats went the wrong way. But thankfully, she just exercised, took care of it, because we went up. At the time we were living close to you, we went up to Hammond Hospital to see their sports guy about possibly having to operate. So you see it extends all the way around. This doesn't really do it justice. That's there. And a lot of times they have other stuff that's in there, fatty pads for cushioning. We'll get to the menisci, these cartilaginous discs, and it's not only in the knee. So do they improve the fit? Absolutely. Do they stabilize? Not necessarily, but sometimes. Do they reduce wear and tear? Not always, but sometimes. And then bursa and tendon sheath. Some joints come with them, some do not. We're almost done with this first presentation. Okay. They're not so much in the joint as they're part of it. So they're basically little packets of these synovial structures, and wherever big, thick things rub together, typically they're found there. The knee and the shoulder have naturally occurring ones. They're there in the elbow. They're there in the foot by the Achilles tendon. Those are always there, these bursal sacs. Tendon, wherever tendons go around the bend, from your arm, from your forearm into your hand or your wrist, from your leg into your foot and ankle, these sheaths are like little tunnels or passageways that guide the tendon in. And and when we operate, we have to make sure that they go back through the appropriate sheath. It's kind of because you're under tension. It's like one of those Venetian blinds. You know, as you're a kid, my kids would play with it and it snap back up. They do that. Tendons are like ropes, but the liners have a great deal of elasticity. This is the one we'll talk about the most. This acts as a super stabilizer. This is what they call, when you hear about a ruptured biceps tendon, the tendon doesn't rupture. Tendons are like ropes. They don't tear that easily. What happens is that is in that intratubercular groove that you probably studied between the greater and lesser tubercle of the humerus. It actually pops out of its sheath, and you have to basically kind of deepen it, put it back in the sheath, stuff it back in, oversew it. It's not a whole lot different than a lot of things we do sewing-wise. It's really what sometimes surgery is as simple as reinforcing it. That's there. Here's a bursal sac, and we'll look at all those. We're going to stop here. That's where I stopped previously, and then we'll have the second half of the lecture thereafter. So I will stop recording for just a jiff. Give my voice a fair chance. Give me 5-7 minutes to catch my breath.